Well, I want to thank all the speakers for this wonderful start of the day. Uh, in spite of the hiccup that we had at the beginning, I must say that all the lectures were really great and wonderful. Maybe there was some overlap, but that's always useful. So I see that we have some questions here. So the first one is for Asma. You have been complimented for your wonderful lecture. And then the question is, can we make final decisions about termination in cases of spina bifida diagnosed in the first trimester, or rather make it later? I think this is a very relevant question.
Well, thank you, Katia. I think this is a really important question. And because there's difference between screening or markers and diagnosis. And still, I think for me, the diagnosis in the first trimester or at any stage, really, you need to see the lesion in the spinal lesion. And obviously, there are different types or different morphology of the spina bifida. So where actually you will have a sac, the myomeningeal, but also you might sometimes you don't have a sac, but you just have the defect, like myeloschisis. So, and therefore, if you see the defect, if you're 100% certain of a diagnosis of spina bifida in the first trimester, I think it's very reasonable to offer the option of termination of the pregnancy. I don't think it's fair to insist that the patient have to wait until the second trimester. But if I see just the marker and I cannot demonstrate the defect in the spine, I will be cautious and I maybe bring the patient back in 2 weeks and I'll do transvaginal ultrasound scan. I'll try to use this 3D to be able to look at the defect or demonstrate the defect. So I wouldn't really be comfortable to offer termination of the pregnancy until I'm 100% certain of the diagnosis, particularly when it is isolated. Of course, if you have associated anomalies, I think that's fine, it's reasonable. But when it is isolated, I will be careful. Once I see the defect, or I'm 100% certain of the diagnosis, I think it's very reasonable to offer termination of pregnancy.
So I would like to ask also the other panel leaders, what do they think about this? Do they agree?
Yeah, I agree. Asma makes a very valid point. You need to distinguish between screening versus diagnosis. And I think these markers are only markers to indicate that there may be spina bifida. And like any markers in ultrasound, there are false positives and false negatives. So you need to be absolutely certain because the lesions are tiny in the base of the spine. I think I'd separate them into two different groups, or three if you wanted to. Meningomyelocele are the 85%, and they appear as a bubble on the spine. And I think if you look at those, there's a significant proportion which are not appreciated by examining the spine. I think we probably could improve on those. We talk about a 30% detection rate. And I think once you see the head signs are there and you see the bubble, as Asma says, well, they are diagnostic. When I say the bubble, you do a multi-planar analysis of the spine. You see on sagittal, axial, and coronal, and you confirm exactly the landmarks that you see at the second trimester. They're there. You just need to magnify. I think the really challenging group is where you see the cranial signs and you've got a myelocele. And I showed that way of example in my talk. Where the myelocele was so subtle and you couldn't see it until the fetus had turned into an absolutely ideal position. But I still required multiplanar analysis before I could give certainty to that diagnosis. But the key take-home message, I think, in that question, and Katia, the way you phrased the question in a sense is that if there's ever uncertainty about spina bifida in the first trimester, is then you bring them back. And then the next question is when do you bring them back? Well, in a sense, the answer is when do you see the banana-shaped cerebellum? And the answer is 15 weeks. So in fetuses with an open spina bifida, the banana-shaped cerebellum will be evident by 15 weeks. And in fact, in a small proportion, you can see them at 14 weeks. So in practice, when we're faced with that difficult scenarios of the myeloceles, yes, we will bring them back. We don't wait till 15 weeks. We bring them back to a week later and then go again. And it's a matter of changing the transducers in a different fetal position. But you have to see the lesion before you make a diagnosis. And then the last group of the closed spina bifida, which as a general rule are not picked up in the first trimester. They are present. You can't see them because there's no head signs with these, but you see the tiny skin lesion and the opening of the transverse processes, but there's no exposure of the spinal cord. But most of these we miss. I'm not sure, Francesco, if you wanted to add to that.
Yeah, I completely agree, and also depend upon the size of the lesion. And as you show now, the high resolution transducer can directly identify the spinal lesion. So it essentially depends upon the size of the lesion. But I also completely agree with Asma. So we should be very careful and establish precise diagnosis in the first trimester. This is true for spina bifida. This is even also most important for posterior fossa anomaly, and of course, which is most impossible for midline anomaly. So yeah, I completely agree with both of you.
I think one other thing just to throw in, I know of any fetal abnormality that has got 20 sonographic markers used to describing it. And that makes it really quite unique. It tells you a story that is an extremely difficult diagnosis to make. We are talking about tiny lines in space, and I see there's a question here is what is the cutoff for the fourth ventricle? In terms of having a figure in our head, none of us have a figure in our heads. We all go in and we do a scan and we see subjectively something appears abnormal, and then we make the call. And the reason why all these markers have appeared is because these are tiny spaces that don't stand out at us. And I know it makes for publishing papers, a rich area of medicine, because it's so difficult on subjective assessment. But the practical day-to-day take-home messages, when you go to work tomorrow, making a diagnosis of spina bifida is still extremely challenging. And if you'd asked me what are the two markers I would rely on, I would say the crash sign, which I made comment on it. I couldn't let that go, Asma. But we'd actually reported that 8 years earlier. And we quantify that by taking a measurement of the inner board of the occipital bone to the aqueduct of Sylvius. I think that midline shift is easy because everybody knows what a BPD looks like. And then the meta-analysis, which you made reference to, the brainstem to the occipital bone distance measurement, are the two most reliable markers out of all the 20. And I think the data supports that, and subjectively eyeballing it, for me on the axial section, is the most striking marker.
This is a very important point that you are making, because I just refer of our experience in the Netherlands, where the first trimester scan has been introduced recently, and our results regarding the diagnosis of spina bifida are quite disappointing. I have to say that in the protocol that we are using, there is no cranial marker that we have to look at to measure, and that's something that we will have to do in the future. So what you would recommend is looking at the displacement, posterior displacement of the midbrain. And also measuring the distance between the brainstem and the occipital bone. I mean the classical ratio that has been suggested by Shawi. Is that what you said?
I think, maybe I'll let Asma answer the question, but very quickly, yes. At the end of the day, the answer lies. We spent so many years looking at the posterior cranial fossa. The fact of the matter is the intracranial translucency is absent in only 18% spina bifida. So while it was present in 100% in the very first paper by Rabi, it's actually visible and seen, and in many babies, spina bifida completely normal in size. We were looking in the wrong place. The diagnosis of spina bifida in the first semester is really relying on the midbrain to brainstem to find the reliable marker, the best one. So the brainstem to the occipital bone distance, I think, yes, Katia, on the sagittal measurement is the most powerful marker. And then on axial section, for me, looking at the BPD and seeing that shift of the midbrain and brainstem. Asma, do you agree with my
yeah, we always agree, Simon. But just maybe if I play the devil's advocate, because to some extent, I think you're absolutely right. There are so many markers that have been published. And when you have so many markers and something that's been studied for years, this story goes to 10, 15 years, and we yet don't have a formal screening program in the first trimester for spina bifida, not like Down syndrome, for example. And I think in my humble opinion is for two reasons. One, that's sort of very much unique to where I work, which is the United Kingdom, which is we screen for something if we identified in the first trimester there's something that you can do about it and improve the outcome or save money, for example. And actually diagnosis of spina bifida in the first trimester does not. Because I think we just discussed now that we still, a lot of the times, we need to bring the patient back to be 100% of the diagnosis. And therefore, often, actually, the diagnosis is made 100% in the second trimester, maybe early second trimester, but it's not in the first trimester. And the fact that actually, of course, we will talk about the fetal surgery and the potential benefit, but the truth is that it doesn't really make advantage to the fetal surgery, the diagnosis spina bifida in the second trimester compared to the first trimester, because the surgery is done later in the second trimester. So I'm very pro first trimester screening. This is what I do. This is my everyday practice. But as I said, if I would play the devil's advocate with sort of my hat on of thinking from a screening committee when they actually make decisions. The other thing, which I think is a point that we discussed, is the fact that it is actually challenging. It's not easy. Because the views that we looked at, so that the axial view and the crash sign or the displacement or the posterior shift of the cerebral peduncles, these are not really in the axial view that we take to measure the BBD. They're actually slightly lower. You have to move your probe slightly oblique to look almost at the posterior fossa, to be able to see the cerebral peduncles and aqueduct of Sylvius. It's not the same plane as you do the choroid plexus and you measure the BBD, and where you're actually going to see the dry brain or less CSF. And it's a good sign, but it's not 100%. The mid-sagittal view, which is obviously the one that we all look at the nuchal translucency, and initially fantastic really results by Ravi Chavi, a legend in our field. But actually, when people sort of started to replicate these findings in larger studies, the performance was not 90%, was not 100%. So I think this is the story of the nuchal translucency that for Down syndrome that we all want to replicate for another defect has not so far. And perhaps because we still need to do more research, that's why people are looking at, perhaps maybe you need to combine the ultrasound with the biochemical markers or something. But I think, as I mentioned, to play the devil's advocate, is it really beneficial to the patient and the healthcare system to diagnose it in the first trimester? But I'm happy
I think it is in Australia, Asma. I have to say to you, it is in Australia. So we actually make the diagnosis in the vast majority. I know the UK is under pressure, but it is very much a detectable abnormality in the first trimester. But I think you raise a very, very valid point. And it's where do you take a BPD? And Katja, we've spoken about this before because I'm not even sure it's in the issue.
Yeah, Katja presented it actually in your meeting, I think last week or 2 weeks ago, and she presented the data from New Zealand. And I was extremely interested because it was really nice. And she was extremely honest when she presented the fact that actually the performance in the first trimester was not great in a country which is actually, they managed to have first trimester screening. It's, the sonographers are good. So it may be slightly similar to the UK to some extent.
Yeah.
Well, but I have to say that first of all, in the protocol, there were no landmarks for spina bifida. And second, the results are referring especially to the first year of the implementation. And even if you have a very experienced sonographer in performing the second trimester scan, it takes time before you really get acquainted with the with the first trimester. And there is another point that's in the protocol, there is this, let's say, possibility that if you don't feel that you can complete the protocol, you just say, I can't complete it, and then it will be completed in the second trimester. Probably also this should change because it postpones many of the diagnoses to the second trimester. When you feel a little bit uncertain or that you don't feel confident in making a diagnosis, you just can postpone it. But anyway, these are all.
Can I just maybe add one more thing? So the data from the Fetal Medicine Foundation, which is, it's one of the best centers in the world, where the training and there is a protocol and there is enough time. It's not really restricted with the time. The scan finishes when you've looked at everything. And even in the centers in the UK, the increase from about 14% before 2009. And I know that after the IT and all the markers, the protocol included routine assessment of the mid-sagittal plane and looking at the IT, looking at the brainstem to the occipital bone distance. And the latest data was 60%. Not great. Right, so definitely improvement.
That's pretty good, Asma. 60% is a big improvement.
Not for a screening, not for the implementation of routine first trimester screening compared to Down syndrome.
Yeah,
the performance
we can still improve.
90%.
Yeah.
So you're right. I'm very pro. I think for me, what is really, really important in my everyday practice is that if a patient had a previous pregnancy affected by spina bifida, and actually, she's coming in the first trimester because we want to rule out recurrence. For me, absolutely, I would look at all the markers in all planes and transvaginal, try to interrogate the spine, because you want to really, for this particular patient, you want to give her reassurance that this baby, there's no recurrence in this pregnancy. But do we look for it? In my practice, I do, but in the UK, it's not routinely integrated in the protocol for 99% of the hospitals.
If you're one of those women who's in the 60%, you'll be very happy the diagnosis is made at 12 or 13 weeks rather than the diagnosis has been made.
I think I would be very unhappy that I have a fetus with a spina bifida.
Yeah, but I would press ahead. I mean, I think we all agree.
I agree. I think
we all agree it's a challenging diagnosis.
But
at the end of the day, it's difficult.
But unless you want to improve and you want to actually improve the diagnosis, you will never get there. So I'm very pro first trimester scan.
Yep.
So can I add
sorry for interrupting. We should carry on with the rest of the questions that have been posed by our participants. And so one relates to the lectures given by Francesco and Simon. The interhemispheric interruption is, according to Simon, the cavum velum interpositum, and according to Francesco, the third ventricle. Can you please clarify this?
Yeah,
sure.
Go
ahead, Francesco.
Yeah, so essentially, so when we look at the interhemispheric fissures, so the anechoic structure, it might relate it mostly to cavum velum interpositi, but it depends upon at the level when you are looking at, because the cavum velum interpositi, which is more or less is a virtual cavity, in most of the cases in the first trimester is not a virtual cavity, but slightly positioned posterior inferiorly to the third ventricle. So they are essentially anatomically, so if you look at the anatomy of the brain anatomy, they are in continuation. So it might be that when we go from the transthalamic view, and we know that the third ventricle is between the two thalami, to the transventricular view, we go from the third ventricle to the cavum velum interpositi. So it depends upon the plane in which you see it. So essentially, we are not saying something different. Mostly it refers to the cavum velum interpositi. So when I was showing on the video clip, which was very fast, in most of the cases, so when you go down at the level of the ventricle is cavum velum interpositi, it might be that when we go up, so slightly higher than the ventricular view at the level of the thalami, it is the third ventricle, which is a very long it's a very long ventricle. It's a tiny, but it's a very long ventricle. So that's what I mean. The anteroposterior diameter is very long.
Okay, I hope that everyone will be satisfied with this kind of a semantic discussion. So in actual fact, whether we name it one way or another, we are referring to the same anatomical region with some very subtle difference.
We are not making any diagnosis of an anomaly based upon this fissure. So,
okay, great. So then there is another question. How does the appearance of the choroid plexus of the fourth ventricle change in open spina bifida? Who wants to answer this? Asma, I think.
Sure. So the choroid plexus, you would see subjectively that actually the brain is dry. And what I mean by that, normally you have the choroid plexus in the axial view surrounded by the CSF and then you've got the skull bone, and you've got the falx in the middle. And actually, when you see that there's little CSF, there's not much fluid because the choroid plexus is filling most of the lateral ventricle, that's when you think, oops, that's a qualitative assessment. The quantitative assessment is a paper that we published in the American Journal, where you actually measure the length of the choroid plexus and the longitudinal diameter divided by the occipitofrontal diameter. And we published obviously the range. We also did the MOMS, and we did a calculator to give you the estimates. And that we showed that it is high predictive accuracy for cases of open spina bifida. Like anything, when you become screening or prediction, you need to validate it, of course. But that would be what would be striking. So I showed you the data, that qualitative assessment, and Simon said that, is often our practice is this typical the pattern recognition. You see some things, oops, saying that make me suspicious. And then this is the time where either you refer or you actually measure, so you have more quantitative assessment, or actually go straight to the spine and interrogate the spine looking for the defect.
And if I can ask, the position of the foreventricle is especially important for posterior fossa anomalies involving the vermis rather than spina bifida. In this case, is the position, so all the foreventricle is pushed downwards. So rather than the anomaly position of the choroid plexus, sorry.
I think the question, though, was relating what happens to the fourth ventricle what happens to the choroid in the fourth ventricle asthma. It wasn't.
Sorry, I saw the choroid plexus and the lateral ventricle. Forgive me. So yes, so normally when you actually look, and I think this is all certain in the last few years, I think our understanding and our ability to demonstrate the posterior fossa in the first trimester using ultrasound, I think has changed really with all the work that's about the first trimester neurosonography, and being able to really understand anatomical. Certainly 10 years ago, I did not really have the same understanding of the appearance of the fourth ventricle and the third trimester, and actually being able to distinguish the choroid plexus of the fourth ventricle. And I'm happy to share my slides again and show you this nice slide where there is really demonstrate that you see the cerebellum, you see there is a black space behind, which is the fourth ventricle, and there is a two dangling bits on each side, which is a choroid plexus. This is echogenic, and then followed by a black space again, which is a cisterna magna, and then you've got the occipital bone. And in cases of fetuses with open spina bifida, because you have this displacement, the posterior shift of the brain, so almost this posterior fossa is squashed. There's not really much fluid. So you don't really see clearly the choroid plexus of the fourth ventricle. In fact, you don't even see the fourth ventricle or the cisterna magna. When Rabbi Chawi first described IT, there was this confusion. Is IT referring to the fourth ventricle, or is it referring to the cisterna magna? To some extent, it doesn't matter, because actually the whole space, the whole fluid is obliterated, and therefore you don't see normal IT, or the IT is very small. I hope that I answered the question.
I think you did.
Yeah, thanks, Asma.
I have a last question, which is not written down by our audience, and relates to the anomalies of the choroid plexus of the lateral ventricles. Very often in the first trimester, we see either a hyperechogenic or a very asymmetrical choroid plexus. What should we do?
I think asymmetry of the choroid plexus is probably the norm. So they're frequently asymmetrical. I think probably the more challenging thing, particularly those who are starting out in their training, is when you look at the posterior 1/3 of the choroid plexus, they have a irregular lobulated papilliform-like appearance, and they can look quite troubling. But this is a normal variation, and don't be worried about the irregular, craggy-looking posterior 1/3. The anterior is smooth. And then there's the choroid plexus cyst, and I think I gave just a reference paper to that in one of my slides, and I made the comment, most of these are not, first of all, make sure it's not associated with trisomy 13 or 18, so you need to go through the motions and treat it seriously, because it is a marker. And once you've gone through looking for the association of 13 and 18, and there are no markers to support that, well, then these regress and disappear with time. And then the last group, some of them, which we've had a collection of over the years, of these striking, the entire ventricle appearing by these Swiss cheese appearance of choroid plexus, and they disappear also with time. So I think the take-home message is be very conservative about what you say to patients when you see these variations in the choroid plexus.
Great. Okay, any other question, remarks from the panel?
Just very quickly, Katia, there's a comment about, sorry, go ahead.
No, the question about ventriculomegaly.
Sorry.
Yeah, there's a question about ventriculomegaly, and there's only actually, to my knowledge, 2 publications in relation to ventriculomegaly in the first trimester by measuring the area of the choroid to the area of the lateral ventricle, or the length of the choroid to the length of the ventricle. But if I can just push them aside first and say, number one, in ventriculomegaly in the first trimester, we do not measure the atrial width. It's of no use. Number two, it's very rare to be making a diagnosis of ventriculomegaly in the first trimester, and it's usually severe, and it usually relates to aqueduct stenosis or structural brain malformation, which is I gave a very rare case, which we put to print, of agenesis of the corpus callosum, which we couldn't make the diagnosis, by the way, in the first trimester. So it's an uncommon clinical presentation, and usually you subjectively recognize that it's abnormal, and then you go to the charts. There's no place to routinely measure the lateral ventricles in the first trimester. Subjective assessment is the play. I don't know if anybody else agrees with me. Asma?
Can I just, because I think I saw your slides and it didn't include our paper. So we published, yes,
sorry,
I'm very disappointed.
Oh my goodness.
That's okay. So we did publish actually a paper about the choroid plexus, the area of the choroid plexus to the lateral ventricle in the first trimester. And I think you're absolutely right. Actually, the performance was good for cases that later developed severe ventriculomegaly. It wasn't really very good for the cases that had mild ventriculomegaly. And I think the obvious, and you're right, there's no reference ranges for the lateral ventricle, but there is, and this, some people say dangling choroid plexus. So often sort of is striking, again, this pattern recognition when you see it first and say, there's too much fluid in the lateral ventricle and the choroid plexus is dangling. And I said, like we did the RO curves, we did also calculators to give you the individual risk, but I don't think it's very good for mild. It's good for severe ventriculomegaly. And in my practice, I think the way I would use that is, again, a previous pregnancy with ventriculomegaly, particularly severe, patient coming in the first trimester, they want the reassurance. I think I can do the ultrasound scan. Of course, if I see that, there's high chance of recurrence. But if I see completely normal choroid plexus and the proportion of the choroid plexus, lateral ventricle, I'll be reassuring, but it still is not 100%. So you still have to follow up this pregnancy. It's here again in the second trimester.
Thank you very much. We have to close, and we wait you. We will see you back in at 11:30 Central European Summer Time. See you. Bye-bye. And thank you very much to all the panelists.